Goals of care is a conversation that a physician, supported by a nurse practitioner, may have with you to discuss with you at your point in your life, in your disease, in your illness, what your choices are, and that we're going to base a conversation that is based on your values, your beliefs, and any advance directives you may have had.
The goal of care is a new paradigm shift from the Windsor Regional Hospital based on a patient-centered approach to integrate clinical and medical care for a patient basing on their values, beliefs, and what they really want to do. It provided a framework for how to approach care of the patient. It also provides tools for how the frontline workers, physicians, most responsible physicians, how to carry out this mission. This goal of care is based on a conversation with the patient in preparing the advance directive as well as planning their treatment and care. The most responsible physician usually are the one doing the conversation, as well as the nurses, the nurse practitioners who are participating in the care. There are three main topics to consider. The R means resuscitative care, the M means medical care, C means comfort care. The resuscitative mode is carried out entirely in the ICU. It involved life support, it involved life-sustaining treatment, also involved the level of whether you should be intubated or you should have chest compression.
Yeah, hi, Mr. Smith. I'm Dr. Malice.
Hi, Doc.
Listen, I understand that you just got to the hospital.
Yeah.
Okay, your wife has been involved in a pretty big car accident.
Okay.
She was admitted through the trauma team and she's in the ICU now. She's completely comfortable, but she is on life support. She has a breathing tube in and the machines are breathing for her.
Okay.
She's been seen by neurosurgery and she's scheduled to go down for an intervention to take some pressure off of her brain. There's some swelling there. So she'll be going down to the operating room within the hour to relieve the pressure off her brain. The neurosurgeon will be taking her down. There's anesthesia already down there. She has a breathing tube in, as I mentioned. She's very comfortable. She's on medication. She's not feeling any pain or anxiety, but she is critically ill, and she is on life support.
Okay. What's the next steps?
Next steps, very simple. We're doing everything we can. She's going to go down to the operating room. The surgeon will come in and talk to you and describe the risks in the procedure itself. Right now, it's too early to predict what's going to happen. Brain injury is very tricky, and it often takes a few days to let the brain swelling subside and see how she's going to do clinically. The only thing you need to worry about right now is yourself and your family. We're going to take care of her. From my perspective, I'm going to support her. The life support that she's going to get, the ventilator, all the lines and tubes are just there to help her heal. All that stuff doesn't fix anything, but it does keep her comfortable, and it allows the brain swelling to come down and all the other problems, the damage that she's had. She's had a bit of bruising on her lungs, a little bit on her spleen. All those things are going to settle down, and the life support that she's on will give her time to heal. And in the meantime, we're going to do everything we can. In this situation, you're the substitute decision maker. As her husband, you're the person I'm going to go to when I have to ask questions about care.
Okay.
Who else is in your family?
We have young children.
Okay.
And her parents.
All right. I mean, and they'll all be involved. I can have family meetings with everybody. As many people as you can cram in the room, I'm fine with it. But at the end of the day, I'll be asking you and your family, but you specifically, to help us make decisions about her care.
Okay.
Okay. Has she ever had discussions about if the brain injury is so severe that she might not recover or might not wake up?
Yes, she has. Yeah.
Okay. And what did she say to you?
She didn't want to be kept alive.
Okay. And that's a tough one. I think nobody wants to be kept on life support without the chance of getting better. But the most important thing that you need to know right now is we're going to do everything to make her better, And those kind of discussions, those decisions, you might have to make in the next few days, but I'll help you make them, all right? Her body's gonna decide those things for us. And lucky for us, you've had that conversation, which is really good. She's told you what she wants and what her goals of care are. My job right now, get her down to the operating room, get her well, keep her stable, and let her heal. If she gets into a place where we think she can't heal, or other organs begin to fail and we can't help them, that medicine won't work, life support won't work, I'll be very frank and I'll tell you that. But I won't leave her in a place that she can't recover from.
Okay.
The medical mode is entirely in the outside of ICU. They are for the cure and control of the patient's symptoms or disease without using the ICU or without thinking it appropriate. The third level, the comfort, is a pure symptom control.
So Karen, we've had certainly a few conversations, and I hope, as you understand from the conversations we've had with the other healthcare members of the team, that we've essentially come to a point where the medical management thus far has brought us to a point where there really isn't a therapy that exists that could either A, provide curative intent or a curative possibility for the disease, or B, really offer management that could halt the disease as much as I think you would like, in keeping with some of our previous conversations. So essentially what we are saying, I guess, together is that the disease has reached a fairly extensive point. Has that been communicated?
Yes, that's
Yeah.
my understanding as well.
Yeah. And generally and again, we've had conversation, sort of simultaneous to other healthcare providers, and generally when we arrive at a point like this, certainly in keeping with the rest of the journey, our focus kind of always rises to the top, and that being comfort, right, and quality of life. And so we naturally shift to making sure there aren't elements of your day-to-day, whether physical, emotional, spiritual, psychological, financial, anything that afflicts you that is diminishing that quality. And do you think that'd be an okay place to take this conversation?
Yeah, I think those are my concerns. I just want the time that I have left to be high quality. I want to be able to spend time with my family at home and maybe a little bit of travel, so.
Okay. And for sure, you sort of nailed it on the head, because we try to practice in a patient and family-centered environment. All those people that are around you are in many ways just as important. So the team that will be by your side is there for you and for them to enhance that quality as much as possible.
Okay, that's really comforting. Thank you.
Okay.
There are two parts of the form. The first part is the goals of care destination, the R, M, and C, and dating the time, the person who recorded those destinations. The second part is a tracking form, recording the content of the conversation, when and where did it take place, and what is summary of the discussion. And there will be a continual record that should be incorporated in the patient's chart, and also could be portable and transferable to the family physician's office.